said on this morning's webinar, the purpose of these webinars really was our attempt to keep the momentum around the normally in-person event, Digital Health and Care Learning Network Day, we would be having this week. And we wanted to be able to share some of the experiences that the different parts of the public health sector, public health and care sector are having in relation not just to COVID, but in the deployment of digital tools. And obviously COVID-19 has affected everything that everybody is doing. So it makes sense that we have an opportunity to talk about some of that work as well specifically. So I will just hand over. Karen, if you just say next slide whenever you like.
Hi Nessa, let's go straight in for it then. Next slide, please. So first of all, thanks for having me along today. I just want to keep this informal, so feel free to drop questions in the chat, and obviously there's time at the end. First of all, I'd like to just start with a bit of the context. Social care traditionally has sort of been a bit of an unsung hero. However, in the last few weeks, it's certainly been seen as the forefront of the coronavirus response, and digital obviously has a key part to play in that. But before we go into a bit more about the techie aspect, I thought it would be helpful to provide a bit of information on that background context. So most people don't realise that actually 37,000 people will sleep in a care home tonight, and around about 65,000 people are supported in their own homes. Maybe in contrast to that, you see only 17,000 stay in a hospital. So it's quite a large sector, and I'm not sure that public message is there. So just to show you how important technology is in that sort of making the efficiencies in that sense. People come into care because they care. That's the fundamentals of this. In Scotland, around about 89% of providers are from the independent care sector. That comprises of private sector, charitable and voluntary sectors, and we're seeing an increasing number of employee-owned organisations now. It's a sector founded on human rights, and I've put this quote up. This came out of some research that we did with some frontline social care staff. So just to give you that bit of that context and that investment that people who work in social care have in their roles and in what they are there to do in terms of supporting people. We all know that we're facing increased demographics, and as far as I'm concerned, that's great because it means I can annoy my kids for longer. But obviously the stark reality of that is a predicted 85% increase of those aged over 75 in the next few years. What's happening as a result of this is we're seeing a rising eligibility criteria, which is making care homes increasingly specialist in the type of work that they provide and the type of service they provide. It's almost a changing reality of mini hospitals, where 5 years ago people would walk into a care home and expect to be living there for some time, for many years, some even 10, 15 years. Now people arrive in a wheelchair, usually at a point of crisis, and they often live there for around about 18 months. It's in terms of specialist support, we're seeing significant numbers of people with multiple comorbidities, advanced dementia and other neurological conditions, and a significant increase in those who are requiring sort of palliative and end-of-life care support. So social care is actually an economic contributor that sort of contributes around about 3.4 billion to the Scottish economy. And what we're seeing is it's being increasingly recognised as that enabler of economic performance and of community well-being. That's for various reasons, both direct and indirect. For instance, it allows people to go back to work by supporting them to care for other family members and so on. As I said, it's a large sector, so we've got almost the same number of people who work solely in adult social care as who work in the whole of the NHS in Scotland. So that's around about 6% of the total workforce. It's around about 53,500 staff, and that's 4,500 nurses. And what we're thinking of in this tech context is how do we support our social care staff to embrace technology and to make sure that it's implemented in such a way that it's an asset for those who are accessing care and support. So we did some work with the Glasgow School of Art, European School of Innovation and Design, And some of the key themes that come out of that were about the social perception of social care and the capacity, and actually that our staff are highly skilled. You know, they have to be professionally registered, they have to undergo a series of training to be able to work in that role. So for them to be able to adopt technology in such a way that it's an asset and supports them in their roles means that they would also need to, you know, access further training and support in that. So we've been working with the SSSC, who are the regulator of the workforce, and they've been creating learning and development tools and open badges and technology. And we're also have been working a funding bid with the Care Inspectorate, who are the regulator for the way that care is provided. And that's to support inspectors who might traditionally not have recognised the asset that technology could provide. Would you mind popping to the next slide, please? Brilliant. So I thought it would be helpful to give a quick rundown of a few things that have been happening. And also just want to add in there something that Scottish Care has been doing since COVID-19, and that's our tech device network. So we've been doing a matching service. We've had some organisations donating pieces of tech equipment to us, but also anyone who has a piece of technology, iPhones or you know, pads or whatever, or laptops that they're no longer using, we can have those reconditioned and repurposed and put out to care homes, which is enabling people who live there to connect with their families, and also to connect with other sorts of communities. So Luminate have been doing arts workshops every week and all the sorts of things that we've all been doing in our own homes ever since lockdown began. So before COVID-19, and obviously these things are still going on, here's a rundown of a few bits and pieces that have been happening and actually the impact that they're having. So one of the things that's been running now for a couple of years is the monitoring of vital signs, and the purpose of that is to actually to monitor people's well-being and support them to be independent for longer. And what we're seeing as a result of that is it's reducing unplanned admissions to care homes, and it also values care staff. What we're seeing is it's breaking down those boundaries between health professionals and social care staff, as health staff are starting to recognise the skills that care staff have, because they're able to give evidence as to the well-being of the people that they're working with. So in a 6-week trial, we saw unplanned GP visits reduced by 35%. And admissions to A&E reduced by 70%. I mean, these are huge figures. And lastly, in that, unplanned admissions to hospitals also reduced by 35%. So people are able to stay safe and well, living in their own home, whether that's a care home, for longer. Other things have been around about wearables. So many of us wear smartwatches. I've got mine on today, for instance. They're low cost, they're fairly easy to access. So there's an organisation called ARMED who developed a system that measures gait and water intake, movement. It also has an alert system built in, so it can contact family members or care staff, so on. And since they've been using that, it was first implemented in Dumfries and Galloway, they saw no falls within a 12-month period. Now that's huge, because in Scotland, actually, unplanned admissions to hospital as a result of falls cost Scotland around about £500,000 per day. So something like that sort of low-cost wearable has a huge impact on people's well-being and on the public purse. I've been doing some work in Aberdeen on improving delayed discharge. You may or may not be aware, depending on who's in the audience today, is that actually we're quite siloed in our thinking. So our health data is here and our social care data is here, and never the twain shall meet. And obviously that causes great challenges, particularly when we're looking at people who are coming out of hospital to move back into their own homes or to move into care homes. We were finding that they might not end up getting the right care and support that they need, or they might end up going to a place that has a certain specialism when actually they could do with somewhere, slightly different. So what we've been doing is a lot of work mapping flow. So what data do we capture before they come out of hospital? What sort of place would they like to go to? Because remember, one of the fundamental principles of social care is based upon choice and control, and that data wasn't going with that person. Now we are seeing much more appropriate matching. People are moving into care homes and staying there because they end up where they need to be and somewhere that they enjoy being. EMAR is another example. So that's electronic medicine recording. And what we're seeing as a result of that is we're really reducing medicine errors. It's also reducing administration times. That's freeing up care staff to get back to doing the job that they came in to do. And that's spending time with people, not doing that bureaucratic form filling stuff, because the electronic systems free them up to be able to do that. We've been doing a lot of work combining that with a wider medicines waste protocol and collaborative working with our local pharmacy teams and the care inspectorate. That's been saving hundreds of £1,000s a week in Angus alone. Sorry, not hundreds, tens of thousands of pounds. I've just written a typo there. Goodness me. Saving tens of thousands of pounds a week in Angus alone. Many folk are aware of electronic care planning systems. I mean, they're really fundamental. People use them day in, day out. They've got more and more sophisticated as time has gone on and far easier to use. So some of them now work on photographs, on systems, so you can get there much faster. Again, that's freeing people up from doing the form filling stuff back into being responsive, doing care. They also have alerts built in. You know, this person hasn't maybe moved out of the room for a while, so can you go and check on them, stuff like that. It's just enabling people's health and well-being to be, you know, right at the forefront of people's minds. Other things that are happening maybe outside of the sector, so working with banks who are developing online banking that is much more simplified. It's designed with paid carers in mind so that staff can support people to do their own banking, whereas previously they might have to have a family member doing that for them. There's a lot in the press around about electronic call monitoring just before COVID. Unfortunately, that has been suspended in most areas through COVID. That's particularly in use in care at home. So I'm not going to go into that in detail, but because of the way that's been implemented, it's really been tying people down to the amount of time that they spend with a person. So there are real negatives attached to that. But positives are that it's a useful tool in being able to tell where your staff are, what their routes are, so that they're, you know, not spending too much time traveling, and again freeing them up so that they can spend more time caring. And last of all, I just want to talk about a product called Staff Scanner, which, for want of a better word, is like an Uber for care. Part of that was created to reduce spiralling agency costs, but also offering that opportunity of continuity of care, because you have control about who's coming into your care home, and that stops the, you know, footfall. Reduces footfall, people going from care home to care home, and then you have much more control about, you know, who they are, what sort of care they're able to provide, and so on. But I guess what we're seeing there as a result of that is a cluttered landscape. So what we need to be doing is making sure that's working as an asset. So Nessa, if you could just pop onto my final slide there before we move on to Moira. I just want to talk about some work that Scottish Care has been doing with many other people. So we developed a human rights charter for technology and digital and social care, and we did this working with Scottish Government, with academics, with people who access care and support, with frontline care staff, with care providers, and basically anyone who has a vested interest in how we deliver care and support. And what we've seen is actually much of the work in terms of technology has been very much health focused to date. So this is about shifting that into the social care sector, and rather than taking a product that's developed in one sector and just applying it in another, actually it's back to that fundamental principle of social care. It's based in choice and control, and it's based upon human rights. So how do we make sure that those systems are fit for purpose? And also, how can our staff or our providers who might be purchasing these products can be assured of the products and the systems that they use? So we developed this charter for technology and digital and social care, which sort of outlines basic principles which people who are developing technology should adhere to when they're developing that technology, and our providers should also adhere to when they're choosing technology and implementing that technology. We have recently had a new member of staff work with us who we previously worked with before. So Dr. Tara French will be taking this charter and then, you know, working on ways that we can implement it and get it rolled out into the sector. And just to finish off, she's also doing a project on social care futures as well, which sort of fits well in the technology landscape too. And what she's doing is scoping what the new care normal will be. So some of the learning that's happened since COVID-19 and some of the things that were going on before that, what innovation's been happening, how we've been interacting with technology throughout that period, so that we can set the scenes for the future, and social care can, you know, lead the way in terms of how do we make that fundamental choice and control aspect of the way that we deliver care and support in the future. So that's all from me, and over to you, Moira, to talk about what some work that we've been doing together specifically in COVID times.
That's great, thanks Karen. So as Karen says, my specific role today is to tell you a wee bit more detail about our particular project that we've been progressing. So it's involving DHI, Scottish Care as partners, also working with the Scottish Government, the Care Inspectorate, COSLA, Local Government Digital Office, and a wide range of independent care home and nursing home colleagues. So that sets the scene there. DHI has got a long-standing relationship in place with Scottish Care and some of the others, and that really helped us to accelerate a COVID-19 discussion on where digital might best help support the care and nursing home sector. Initial discussions with key stakeholders, which I would say often took place at funny times and funny mechanisms, texting ourselves at 10 o'clock on Saturday night, Karen. And that was taking place really to help us develop a virtual scoping workshop, which we held on the 31st of March this year to begin to explore this in more detail. DHI used a whiteboard style online tool called Miro, that's M-I-R-O, which we were a bit familiar with through other projects that we've been supporting in Europe. And we used that tool to map the current processes that were being used in the care and nursing home sector for COVID-19 cases, and looked to try and identify common elements across a wide range of providers and where there were shared challenges. As a result of that workshop, we identified 5 key areas for digital activity, and this is just an example of some of the approaches that we took on the day. But the 5 key areas for digital were looking at the need for a consistent and structured symptom checking, which would inform local decision making and support communication where external clinical support was required by the care and nursing homes. The second area was looking further into vital signs monitoring, where that could support the symptom gathering and the diagnosis. A third area looked at the need for a clear recording of what matters to the individual residents, what matters to me, to inform decision making, key points in ever-changing circumstances, and looking at links with families and how they could support that process as well. The fourth area was a requirement for easy access to external services when required, but in a way which continued to support the residents, the staff and the visitors to the care and nursing homes. Fifth area was about supporting social connectivity and activities. How did we avoid boredom, encourage mobility within the sector, and continue to support mental well-being within that COVID environment? Now, some of these areas were reinforced by Scottish Government clinical guidance, which was being issued for the care and nursing home sector. Others were being progressed already, such as the rollout of Near Me, which I know there was a presentation about this morning, using a video consultation platform to provide that clinical support, mainly from the primary care side. Healthcare Improvement Scotland and NES were also developing anticipatory care planning tools, so they'd kicked that off. And many homes had taken the initiative and were introducing a range of consumer digital tools already to support social connectivity, so things like Skype, WhatsApp and Zoom were already being deployed by the care home sector, really to make sure that they were able to meet those needs of family and friends and reach out to external providers as well. So because of that, the workshop participants agreed that our focus would be on the need for structured symptom checking to aid decision making for suspected COVID-19 cases where external clinical support was necessary. Can you flick on to that next slide, please, Nessa? So DHI introduced into the discussions a clinical assessment tool, which was concurrently being developed in collaboration with NES, NHS GGC and a Scottish SME for use in some of Glasgow's emergency assessment centres for COVID. This tool was being built on a tried and tested trauma app, which had already been adopted by NHS Scotland. So some of the technical side of it had already been tried out, and some of the integration side of that as well. This tool was initially reviewed and adapted through the workshops that we were holding. So we had another 2 or 3 workshops with the input from the independent nursing and care home providers. And 2 versions of the tool then emerged from that. One was looking at including decision support elements which were suitable for homes with nurses and trained care assessment staff in situ. And that was using recognised decision support tools such as Restore 2 and News 2, which again, some of you already may be familiar with. The other version was for homes with no nurses on site. We also carried out process mapping, which looked at what the new process would have to be if the tool was being adopted, and in partnership again, we developed guidance for how you would go about using that tool. We then kicked off on the 6th of May a test of change with 10 participating care and nursing homes. So again, this all felt a bit, it felt like it took us a long time, but actually when you look back, it was all happening pretty fast and furious. And the test of change is seeking to see if staff feel there's any benefit from the use of the tool with regard to their day-to-day activities, and if we can identify if the summary information which is generated by the tool is sufficient to enable that top cover external clinical support to be able to provide helpful input. And we had 3 volunteer GPs that are helping us do that. We've also got support from the University of Strathclyde, where we have researchers who are already experienced in the digital health and care sector, who've helped us look at this service improvement opportunity and what kind of impacts we could measure as we're progressing. So this is involving staff surveys, it's looking at particular interviews, and a feedback survey form for the GPs that are involved as well. The gathering of the individual assessments from the care and nursing homes of suspected COVID-19 cases is due to end tomorrow. The anonymous information is then reviewed by the volunteer GPs who will be supporting the project to gather their views on whether there is sufficient information to enable a quick and accurate joint decision-making process to then take place. And often when we think what practice is like just now, there's quite a lot of time that's expended by the staff in the care and nursing homes trying to get through to a clinician in the first place externally. And then there's a bit of discussion and debate that then has to go on, asking for additional maybe readings to be taken or other information to be gathered. So just now it's not a hugely fast and time efficient process that's there. So at the end of the test of change, we're going to develop a review report, which will then be produced, gathering all of the resources and the assets together. So copies of the survey questionnaires, mapped processes before and after, the wireframes and the technical backlog that's being used for the tools, and the training materials. All of that will be gathered together by early June, and then Scottish Care and ourselves will develop recommendations for any next steps and any project proposals for expansion. So just to reinforce, this project development process normally takes months, and we've managed to accelerate that in just a few weeks. It was made possible by the existing good relationships and the networks that were already in place with the key stakeholders, a very clear alignment with clear national strategies and drivers in Scotland, and a recognition that we all had very different skill sets and strengths that we could bring to push this forward. Another positive factor was the fact we were building on existing tested products and trusted suppliers, so we were very quickly able to mobilise that. And we also used the accelerated COVID-19 accelerated procurement processes to help us move forward as well. Not without its challenges. So the key challenges that I'm reflecting on, and I'm sure Karen will have others that she wants to add, is how we kept up to date with very swiftly changing guidance that was being issued. Digital kind of made that possible, and changes in practice that were going on as well. although this is a very much welcomed thing, there was a reduction in the number of newly suspected COVID-19 cases during the period where we kicked off the test to change. So we had less cases in which we were able to test the tool out on as we were progressing, and had to take an adjusted approach to that as we went forward. Also, the introduction of the wider spread of testing, which again was a very welcome development, but it moved the use of the tool from supporting decision making on diagnosis to much more about care management and how to support individuals. And also we're recognising, and Karen's made reference to it already, there's a plethora of other digital solutions for this sector already emerging, and some that were there before. And what we're looking at is how do we coordinate and are cognizant of the other developments that are taking place, and how do those work together rather than any unintended duplication as we go forward. And that's me.
Thanks very much, Moira. That's brilliant. I'm just going to stop my screen share, and I'll just encourage people, if they have questions, to use the chat, or you can unmute yourself. But as we have more than 30 people on the call, just in case we get a sudden rush of voices. But we do have a quick question while I do that, and it's from Sharon Levy. Sharon is asking, where is the family in the shared decision-making process? I think that's probably for you, Karen. Sharon, you might want to elaborate a bit. But
hi there. Yeah, if you could give me a bit more information, if it's in terms of the clinical assessment tool itself, so this would be sort of in the moment, real-time assessment. Obviously the care provider would contact the family to keep them up to date if they were to see any change in that person's health and well-being. Obviously also some of this depends on the context of whether or not you have guardianship or oh gosh, why am I having a mental blank? What do you call it? Attorney, power of attorney as well. So there's quite a legal framework and a legal context into who you can tell what. So the purpose of the tool is that in the moment, real-time way of capturing information and taking that through that clinical route. But obviously the care provider would have a responsibility to keep family members informed in that process. If it's about something different, feel free to pop that in the chat as well, and I can come to you on that as well.
Thank you, Karen. And I think we had another point just raised. Sean says, thanks. Where will updates on the project be shared, please, Moira? It sounds like a great way forward.
So we would intend to share, as we usually do, we'll share through the DHI website and through our social media channels, and I'm presuming that Karen will be doing the same through Scottish Care.
Yeah, absolutely. We would pop things on our website and share through providers, and it may be with Tara coming into her role that there's a wider sort of scoping of tech in social care as well, so it would probably form part of that as well.
I was thinking while I was listening to, sorry, this is Nessa butting in, that it'd be really good to do a session with Tara, and maybe in a couple of months when she's had a chance to do some of that reflection like this.
Not that I'd want to put a colleague up to doing some work, but she's very skilled in the sector and has previously worked with DHI and with Scottish Care, so yeah, she certainly has a lot to share and contribute.
And we've had another question. So what percentage, can you say how many roughly care homes in Scotland are using electronic care plans or electronic care management systems? Read that right?
So, I mean, what you've probably done there is expose that we don't know these things. So we're currently working with the Care Inspectorate to do an assessment of digital poverty in the care sector. And we know that it really, really ranges and actually tends to happen in pockets. So we have some care providers who are fully tech kitted out. Everything is, you know, technology focused, care planning systems, EMR systems, connectivity systems, and so on. Other care providers might only just have Wi-Fi in the reception area. So there's a real need to address some of that digital poverty that we're seeing, and we're hoping that the results of the survey through the Care Inspectorate will help to give us more context in that space, which then means that we can start to address if we think there are different people maybe lagging behind the system. And yes, Neil, the next bit I was going on to is about funding to support technology development in the sector. So that's where we would like to see this next, particularly, you know, with things which are critical to people's health and well-being, like this COVID app, like the Near Me functionality. We need people to be able to access those, you know, and that's quite an urgent rollout required there. So we've been once we get that scoping, we will have an idea of what costs might be incurred in terms of getting those up to speed that might need that, and we're working with Scottish Government to address that.
Okay, thank you, Neil. Thank you. You jumped ahead of me there to answer the question, so that's fab. That's what I like to see. I'll just quick check to see if we have any further questions. Can I actually again butt in, as we don't, and let people have a chance to think? So my question really is to both of you, to Karen and Moira. You mentioned the introduction of the symptom tracker, but also you've explained about the symptom tracker, but also Karen, earlier on, you mentioned that there are a range of digital solutions. Obviously some free solutions even are being used now, but there are a range of things going on. And I suppose I'm wondering, did the care home staff involved find this an extra burden to try and introduce the tracker? Were they open to that? Were they receptive to that? And then a bit more widely, in terms of digital solutions generally at the moment, is your sense that the staff are quite open to see what they can do for them, or are they feeling a bit overwhelmed with it?
I'll say, so I was hugely impressed at the engagement that we got from the independent providers. In fact, I was actually very, very surprised at how enthusiastic they were to look at new products and to help develop those as we went through. So the engagement was superb. I mean, Karen provided many of the introductions initially, but the providers stuck with us through the project and have continued to support. As I referred to earlier, I think the key chat, and obviously the care homes were going through a massive pressure point in the midst of all of this. So again, I was amazingly impressed by them continuing to engage. I think just now the only issue that we've experienced has been the drop in the number of suspected COVID cases. And I know that that sounds horrible in the scenario that we're dealing with just now. But again, they've come up with really creative ideas about how we can overcome that as well. So no, delighted to be working with all of those guys. Karen, anything you want to add?
Yeah, just to support you in extending that thanks to those providers who've been involved, because clearly they were running through this at a point in time when you know they were also delivering fairly intensive support on the ground. But what they've seen is the applicability of this system, where it might actually have potential in other areas as well. So whilst we're in COVID and we're developing it right now, actually in terms of that access or streamlining the way that we symptom check people in terms of being able to speed up access to more acute support, there's definitely a rollout potential beyond the current situation that we find ourselves in.
I think it's also acknowledging there's other great bits of work going on across Scotland. So I'm aware of some work that's going on in Lothian involving some of the same care homes, but looking at different elements like minimum data sets and elements like that. So there's definitely fantastic opportunities to look to expand, even to try and link up with other initiatives and research that's underway as well. So loads of opportunities there.
A couple of quick more questions then before we need to finish. From Anne Hendry. Hi Anne. Do we know how many care homes have an anticipatory care plan in place? I will let you think about that for a moment. We've addressed the question. Karen, you've responded on funding. The next one is, are there plans to create a digital passport, a CPD portfolio capturing learning of digital skills for social care staff? I'll just flag up, we have got a session on Thursday morning with Keith Quinn from Scottish Social Services Council, which some of you may be interested in, about rapid deployment of digital learning. So Karen, back to you. How many residents, is it possible to say, have an anticipatory care plan in place? I don't know if that's possible.
It is not possible, and I asked that question of Healthcare Improvement Scotland last week, so I know that it is not possible. We don't have that data. However, and we know that there, and maybe more actually, is DHI working on this. So maybe you want to pick this up and move towards a digital ACP.
So in terms of ACPs more generally, we did ask the question of the providers at the outset when we were doing the workshops, and again it was a very mixed bag of responses that we got. When we pushed to try and say, you know, give us a bit of an average about where you think ACPs are in place, so non-digital ACPs, I think some of them were really high, some of them were sitting at like 90%. Others were looking at 60%. So yeah, the national position's not clear, and different providers had different practices which supported that. On the digital side, I think there were very few that had digital ACPs at all. But again, we knew that HIS and the National Digital Service were in the midst of trying to develop something there.
Okay, thank you. And on to a digital passport or CPD portfolio for capturing digital skills for social care staff. I don't know if either of you are in a position to say anything specifically.
Probably out with our remit in DHI at this point. I don't know, Karen, if there's anything from you.
So some providers have tech systems linked into their care planning or their staff management systems that will already capture that. And some of those sit external to the organisation, so that travels with the staff member no matter where they're working, so they can access that remotely at any point in time. But I would definitely pick this one up with Keith. It's certainly conversations that we've had, and you know, the SSSE have been developing their open badges in technology and digital skills, so there is a likelihood that that will then move into a specific tech space.
Okay, thanks very much. Just another one. Are there any plans to review the overall effectiveness of specific tools and systems? It's a bit of a minefield to begin to look at systems and to know what is the easiest to use and the most effective. That's a big one.
What's come out as part of this project, and again I made reference to the plethora of other digital tools and products that are now emerging for use within the care home and the nursing home sector. And so Scottish Government under the tech programme have agreed with some of the other key stakeholders to pull together a group that starts to just map, I think, everything that's out there and then consider how it needs to link. So that first meeting hasn't happened yet, but again, I think that's a really useful development to move forward, and that Tara French will be involved in as well from Scottish Care's perspective. So hopefully we begin to see a bit more of a plan emerging and a bit more of really good shared practice that's already happening on the ground, being surfaced and shared on a wider basis, beyond obviously what Scottish Care are already doing.
Thank you, and I think we're almost at an end. Just to say, somebody's also pointing out that it would be great to get a feel of what these systems are, what's working best, etc. So just echoing your point there, Moira. And a lot of people saying thank you, and I just want to say thank you again to you both for taking the time. And we have a final quick one asking us to clarify a bit about Staff Scanner, please.
I can pick the Staff Scanner one up if you want. So that was developed by someone who's actually on the Scottish Care exec, and they own a care home, a couple of care homes in the Glasgow area. And what they found is that they couldn't tell when they phoned an agency to ask for a staff member to come, they would say they couldn't have any control over who that was going to be that was coming to their organisation. And there was a particular person who would often come and they thought they were really, really good. But that person still wanted to work for an agency because they had young kids and they were also caring for their parents. So being able to pick when they were doing their shifts was far better. You know, they wanted to have that control. So this care provider said, oh, well, are you available to do a shift on Wednesday, for instance? And that person said, well, yeah, I can. So then they phoned the agency, but the agency then said, oh, well, I know that person's really good, but I can't keep giving them to you all the time. I've got to share them around the providers. Completely undermining the whole requirement, you know, the whole need in social care to have that continuity of care so that people are working with you know, they build those relationships, they understand people, which means that they can notice any changes in that person's well-being or how they present and respond to that accordingly. We're also seeing really spiraling costs for agency staff as well, and you know, hundreds of pounds an hour at Christmas, things like that. So sort of to try and take that or regain some of that control in the market, it went out to this Uber system of care. It's an app, and effectively works, yeah, like Uber. So the care staff will upload their details, the care home will upload their details. It's a transparent cost, just a single cost per hour. It's clear who gets paid what within that system as well. It's much cheaper than it is to use an agency, and you have direct control over who it is that's coming to work in your care home at that point in time. They also go through all their pre-employment checks, all their registration, and all that stuff is done in the background as well, just to make sure you have that security of the person that's coming in to your home as well. So it's another model in terms of a way to get agency staff. It's worth having a look, just to try different things. Certainly we're having really positive feedback from the care providers that have been using it.
Thank you very much. And just again, final thanks from me. I think we'll call a halt there. We're just over our time, but really appreciate you giving your time this afternoon, and all the people who've joined in and engaged and asked questions. And hopefully at least we don't miss having our Learning Network Day by having this chance to just find out what people are up to and how they're managing. So thanks again. We aim to make the recording and the slides, with permission from the speakers, available in the next couple of days via the Tech website. I'll capture the chat in terms of the references that Karen has kindly shared, and share those as well for people who wanted some references about the data being explored. What we also started doing this morning with the first webinar was to take some of the questions and put them on Twitter. So if you're on Twitter and you want to answer them or talk about them, have a look there for us, and we'll obviously copy Karen and Moira into that chat. But thanks again, folks, and I'll say cheerio.
Thank you.